Welcome to the deep dive. This is where we take your source material, your articles, your research, your notes, and, well, we distill it into the absolute highest yield insights, giving you a true shortcut to being well-informed.
Yeah, think of us as your guides, sort of navigating that stack of information you've provided. We pull out exactly what you need to know, framed for, quick recall and understanding.
Precisely. And today, we are diving deep into some really detailed revision notes you, our listener, shared with us on renal calculi, better known, of course, as kidney stones.
Right. And our mission is to transform these notes into, a memorable, high-yield deep dive, perfect for revision.
It's about finding the essence, isn't it? The crucial points you'll want front of mind based only on the material you've given us.
Exactly. Only what's in the notes.
Right. So let's jump straight in, guided by your notes, to the topic, kidney stones.
Let's do it.
Okay, let's unpack this right from the start. What are renal calculi, according to these notes? How do they define them?
Okay, so the notes define them as hard deposits that form in the kidneys. They clarify that these can vary quite a bit in size and what they're actually made of.
Okay.
And crucially, they can obstruct the urinary tract, which, as the notes point out, is often the source of the symptoms.
Right. The obstruction causes the pain. And there's a related term the notes use, urolithiasis. What does that mean in this context?
Ah, yes. Urolithiasis is, it's the underlying condition described in the notes. It's when the urine becomes supersaturated with salts and minerals.
Supersaturated, meaning?
Meaning it's holding more dissolved stuff than it should, basically. And it's this state, the supersaturation, that allows these hard deposits, the calculi, to actually form.
Got it. Like the urine is holding too much potential stone material. And the notes break down the types of stones, right? This seems like a high-yield point for revision.
Absolutely, yeah. The composition matters. It helps understand causes and treatment. So the notes state that calcium stones are the most common type, by far,
Common.
making up about 80%. 80. Then comes uric acid stones, around 10 to 20%.
Okay.
Struvite stones are less frequent, maybe 1 to 5%. And finally, there are cysteine stones mentioned. So yeah, remember, calcium is the big one.
Primarily calcium. Okay. And the notes mention a couple of specific formation factors like nanobacteria and Randall's plaques.
Yes, those are noted. Specific elements potentially involved at a, microscopic level in kicking off stone formation.
Interesting detail. And what about bladder stones? Are they the same thing, or?
So the notes include bladder stones as a related topic. They point out they make up about 5% of urinary stones.
Ah, so less common than kidney stones.
Right. And they highlight different causes compared to kidney stones, often related to things like bladder outflow obstruction or urinary stasis, where urine isn't emptying properly.
Okay.
Risks are higher with catheters, according to the notes, and they can sometimes be associated with bladder tumors. So yeah, related but distinct causes and risk factors.
Fascinating how the location changes the story. So we know what they are, the types, but how do these stones actually form? What are the underlying causes, the etiology described in your notes?
Well, the notes list several key drivers for kidney stone formation. The primary one, linking back to that urolithiasis idea, is supersaturated urine.
Right, too much stuff dissolved in it.
Exactly, just too high a concentration of those stone-forming substances.
That makes perfect sense. If there's too much solute, it eventually has to solidify. Right?
Precisely. Another key cause listed is decreased urine volume. So if you're not producing enough urine, those substances become much more concentrated. This naturally increases the chance they'll precipitate out and form crystals.
Less water, same amount of solute, higher concentration. Simple physics, almost.
Pretty much. Urinary tract infections are also mentioned as contributing. UTIs can sort of alter the urine environment, making stone formation more likely.
So infection can be a player here.
Yes, definitely listed as a factor. Then there are genetic or metabolic disorders that affect how the body processes substances and, regulates urinary composition.
Internal body chemistry issues.
Right. And finally, diet is called out. Specifically, high intake of sodium, animal protein, and oxalate are noted as significant factors.
That directly feeds into the supersaturation issue, doesn't it?
It absolutely does. It's providing the building blocks in excess, you could say.
Okay, speaking of diet and other factors, your notes have a pretty comprehensive list under risk factors. Here's where it gets really interesting for identifying who might be susceptible, Who is more likely to get these, according to the notes?
Yeah, this list is crucial for clinical context. A
Okay.
major risk noted is history, both having had a stone before, that's personal history, and having family members who have had stones, family history. Both significantly increase your risk.
So if you've had one, you're much more likely to get another.
Yes, a very strong predictor mentioned in the notes. Dehydration from inadequate fluid intake is highlighted as a primary modifiable risk, something people can actually change.
Makes sense.
Diet comes up again, emphasizing high salt and high oxalate intake specifically.
Hydration and diet are clearly recurring themes then, aren't they?
They really are foundational, according to these notes. Medical conditions listed include obesity, hyperparathyroidism, and gout. UTIs appear again as a risk factor linking back.
Right.
Certain medications are noted, things like diuretics and some antiretrovirals, which can change urine composition.
Important to know about medication links. Definitely.
Yeah. Anatomical anomalies in the urinary tract are also a risk factor. Hypertension is listed, and interestingly, immobilization like extended inactivity is included too.
Immobility. That's a bit surprising. Did the notes say why?
The notes don't spell out the exact mechanism here, but generally being immobile can affect calcium metabolism and also cause urinary stasis. Things just aren't flowing as well.
Okay, that makes sense.
Metabolic disorders affecting how solutes are excreted are also a category, tying back to those genetic causes we mentioned.
Got it. What about environmental factors? Anything there?
Yes, exposure to lead and cadmium are specifically listed as risks. Then there are specific urinary issues mentioned. Citrate deficiency, that's low urinary citrate, which normally helps prevent stone formation.
Ah, so low levels of a protective substance.
Exactly. And cystinuria, which the notes describe as an inherited aminoaciduria. Basically, too much of a specific amino acid, cysteine, in the urine.
So it's a real mix: lifestyle, medical issues, genetics, environment.
Precisely. Dietary habits are reinforced again later in the list. High oxalate, urate, sodium, and animal protein, just hammering that point home.
Repetition for emphasis, maybe?
Could be. The notes also list socioeconomic status, potentially higher risk in some groups, and reiterate obesity, specifically noting it as a risk, particularly in women.
Obesity being highlighted specifically for women is a detail from the notes to remember.
Okay. It is. Contamination exposure is also on the list. And finally, the notes pull out specific recurrence risk factors, which are definitely high yield: stone type, family history, having had prior stones, and early onset of stones.
That's a packed list. A lot to keep in mind. So we know the ingredients and the risk factors. But how do these things translate into a stone actually forming? What's the step-by-step pathophysiology described in the notes?
Okay, the notes describe a kind of three-step process. It starts with the precipitation of these stone-forming substances in the urine, basically. They fall out of solution because there's too much of them.
Okay, like sugar crystallizing if you dissolve too much in your tea.
Exactly, good analogy. Next, these tiny crystals grow and they start to stick together, a process called aggregation.
Aggregation, got it.
This aggregation and growth ultimately leads to stone formation. You get a macroscopic stone.
So precipitate, aggregate, grow into a stone.
Yes. And the notes again list the promoting factors for this whole process, echoing the etiology section. Urine supersaturation, reduced urine volume, UTIs, and changes in urine pH or composition. These create the ideal environment for this process to occur.
It all ties together neatly. Now, here's a critical section, especially for revision and, clinical thinking. Differential diagnosis.
Oh.
If someone comes in with these symptoms, what else could it possibly be besides a kidney stone, according to your notes? This is key for exams.
Absolutely key, yes. You don't want to miss something else serious. The notes list conditions with similar symptoms first. Things like urinary tract infections, renal colic itself, which is the symptom caused by stone obstruction, but important to list, appendicitis, diverticulitis.
Right, other common causes of abdominal pain.
Exactly. And other general causes of abdominal or flank pain. So pain in that area isn't automatically a stone, far from it.
Okay.
Then the notes provide additional considerations, which might be less common but are crucial not to miss. These include aortic aneurysm dissection.
Whoa, that's serious.
Very. And there's a vital note. Consider this particularly in patients over 60. Age is a flag here. Pyelonephritis is listed kidney infection, and the notes add that high fever is typically present here, which helps differentiate it from uncomplicated stone pain.
So fever is a red flag pointing more towards infection. Useful distinction.
Exactly. The notes also list acute pancreatitis, perforated peptic ulcer, epididymoorchitis, torsion of testis.
Also surgical emergencies.
Right, sinister back pain suggesting maybe malignancy or other spinal issues, drug misuse, and even Munchausen syndrome.
Wow, that's a really wide net from life-threatening vascular events and infections to, well, psychological factors.
It really emphasizes the need for thoroughness, doesn't it? The notes specifically stress the importance of a comprehensive abdominal examination to help rule out these other potential diagnoses.
Crucial clinical skill. No shortcuts there. Okay, let's shift gears slightly. Let's talk about how common this condition actually is. What does the notes say about the epidemiology of kidney stones?
Right, the numbers. The notes give some specific figures for the UK. The UK prevalence is stated as 10–15%.
10 to 15%, that's pretty high.
It is. And it's noted as being higher in males generally. Globally, there's a clear increase documented, which the notes link to dietary and lifestyle changes.
So it's becoming even more prevalent.
Seems so, yes. It's described as a common condition overall, affecting maybe 1 in 10 people at some point in their life.
1 in 10 people.
Wow, yeah. The annual incidence is given as 1 in 2 cases per 1,000 people per year, and the overall lifetime risk is stated as 5–10%.
So 1 in 10 lifetime prevalence, 5–10% lifetime risk.
Okay.
Definitely common.
It is significant. Regarding the gender ratio, the notes say it started around 3.1 male to female, but this gap is narrowing. Again, attributed to lifestyle changes affecting women more now.
Interesting trend.
Age peaks differ too. For men, typically 40–60 years old. For women, the peak is earlier, often in their late 20s.
That's quite a difference in peak age between genders.
And finally, ethnic variation is noted. Higher prevalence in whites, followed by Hispanics, then blacks, and then Asians, according to these specific notes.
Okay. That paints a clear picture of the who, when, and how often. Now, putting this all together, what does this actually look like when someone presents? What are the key symptoms and signs from the notes under clinical presentation?
Well, the cardinal symptom, as we mentioned, is severe flank or abdominal pain, often called renal colic. This pain is typically due to the stone obstructing the ureter, the tube from the kidney to the bladder.
That intense pain.
Yes. Hematuria, or blood in the urine, is also very common. The notes later mention this can be microscopic, so you might not always see it with the naked eye.
So always check the urine under a microscope or with a dipstick, even if it looks clear.
Good practice, yes. Other urinary symptoms listed are urinary urgency, frequency, or perhaps hesitancy, difficulty starting.
Okay.
And symptoms of a concurrent UTI can also be present, especially if there is an infection brewing alongside the stone.
All right, the two can go together. And the pain itself. Does it have specific characteristics noted?
It does. The notes describe the severity and location varying depending on the stone's size and its exact position in the urinary tract.
Makes sense.
A key feature for recognizing it is its radiation. The notes specify it often radiates to the groin, the testicles or labia, and sometimes the anterior thigh.
That classic radiating pain.
Exactly. And importantly, the notes say the pain can change its location or character as the stone moves down the tract.
So moving target pain-wise. That's high yield. What about other symptoms or how the patient actually appears?
Other symptoms listed include wiggers, shaking chills, and fever again, think infection if you see those, dysuria, which is painful urination, urinary retention if the stone completely blocks urine flow, and nausea and vomiting are very common, often severe because the pain is so intense.
Okay. And on examination, what might you see? What do the notes say?
The notes give a really vivid detail. Patients with acute renal colic often writhe in pain. They just can't get comfortable, can't sit still.
Right, that classic image.
They are usually aparexial, meaning no fever, in uncomplicated cases. There might be abdominal tenderness when you press over the affected loin, the flank area. Bowel sounds can sometimes be reduced.
Okay.
The notes specifically mention testis pain can occur with stones low down in the ureter, but stress that the testis itself should not be tender when examined. That's a crucial point for ruling out things like testicular torsion.
Very important distinction.
Yeah. Blood pressure might be low, perhaps due to the pain or dehydration from vomiting, and they reiterate, again, the need for that comprehensive abdominal examination.
Okay, symptoms and signs covered. Someone comes in presenting like this. What tests do the notes say we should do? Let's look at investigations.
Right, the workup. First line is often urinalysis, a urine test. The notes say this identifies microscopic hematuria, signs of infection like white blood cells or nitrites, and the urine pH.
And the pH matters.
Yes, the notes mention that an abnormal pH can suggest specific stone types. For example, very alkaline urine might point towards infection-related struvite stones.
Okay, what about blood tests?
Blood tests are also necessary. The notes list specific ones: BUN, blood urea nitrogen, and serum creatinine. These assess kidney function and look for acute kidney injury, maybe from obstruction. CRP, C-reactive protein, checks for inflammation or infection.
Standard kidney infection markers?
Yep. U plus E, urea and electrolytes, serum calcium, and serum uric acid. These are looking for potential underlying metabolic causes. And PT, prothrombin time, is also listed as needed if surgical intervention is being planned to check blood clotting.
So check kidney function, signs of infection, metabolic factors, and clotting if surgery is likely. How do we actually see the stone, though? Imaging must be key.
Imaging is absolutely key for diagnosis and planning. The notes state the preferred modality for most adults is a non-contrast CT scan, an NCCT. It's very sensitive for stones.
Non-contrast, so no IV dye needed.
Correct. Renal ultrasound is preferred for pregnant women, children, and young adults. This is likely to avoid radiation exposure in these groups.
Right, different imaging choices for sensitive populations.
Yes. They also mention considering a low-dose NCCT in children or young adults after a negative ultrasound if the suspicion for a stone causing colic remains high.
Okay, it's stepwise approach sometimes.
And crucially, the notes state that urgent imaging, meaning within 24 hours, should be offered to all patients with suspected stones. This seems to be a key takeaway. And NCCT is the preferred method for most adults, explicitly replacing older methods like IVP, intravenous pyelogram.
That's a really high yield point for revision. Urgent imaging for everyone suspected, and NCCT is the standard now for most adults.
Got it. Absolutely. Other investigations mentioned: stone analysis. Once a stone is passed or removed, analyzing its composition is recommended for adults to guide prevention.
How do you get the stone, though?
And here's a practical tip from the notes that's, well, good for recall. Encourage patients to catch the stone. They should strain their urine using a special strainer or even a tea strainer or filter at home.
A memorable, practical detail from the notes. Patients need to be stone catchers.
Yes, exactly. Finally, referral to specialists like pediatric nephrologists or urologists for assessment and metabolic investigations is noted as important specifically for children and young people with stones.
Right, specialized care for younger patients. Okay, diagnosis confirmed via imaging and tests. How do we manage these stones, according to the notes? This looks like a big section with lots of high-yield info for revision.
It is quite detailed, yeah. The notes emphasize that management really depends on several factors: stone size, its location, the severity of symptoms, and the patient's overall health.
Makes sense. Tailor the treatment.
They give an overview of the main approaches: conservative management, which includes pain control, hydration, and sometimes medical expulsive therapy or MEST. Then procedures like ESWL, ureteroscopy, PNL, and finally, prevention strategies.
So start simple if possible, maybe watchful waiting or meds, then get more involved with procedures if needed.
Exactly the idea. For medical management, the notes say small stones, particularly those low down, may pass spontaneously with just good analgesia, pain relief, maybe IV hydration if they can't drink, and antiemetics for nausea.
Okay.
Specific meds are noted to potentially aid stone passage. This is the NP we mentioned. Tamsulosin, an alpha blocker, and nifedipine, a calcium channel blocker, are listed. And of course, antibiotics are used if infection is present or suspected.
Got it. When do the notes say surgical management or procedures are indicated?
Generally, for uncomplicated stones that are larger, the notes mention 10 millimeters as a possible threshold, or if medical management fails to relieve symptoms or the stone doesn't pass.
What are the procedures listed?
The main ones are ESWL, extracorporeal shockwave lithotripsy, using sound waves from outside the body to break stones. Ureteroscopy, using a thin scope passed up the ureter to directly view and remove or break the stone. And PCNL, percutaneous nephrolithotomy, which involves accessing the kidney directly through a small incision in the back, usually for larger kidney stones. Stents might also be placed in the ureter temporarily to relieve obstruction.
Okay, different tools for different situations, and you mentioned emergencies earlier.
Yes, the notes clearly highlight these again under management. Emergencies requiring urgent urology referral are bilateral obstruction, where both kidneys are blocked, and obstructive pyelonephritis, an infected, blocked kidney. These are serious, potentially life-threatening situations needing immediate attention.
Urgent and emergent are definitely different levels of critical, good to reiterate.
Crucially different, yes. The notes also cover initial management details, like deciding between inpatient versus urgent outpatient care based on pain control. Indications for hospital admission are listed. Things like systemic infection signs, risk of acute kidney injury, intractable pain, inability to take fluids, anuria, no urine output at all, or if urgent imaging is delayed.
So lots of reasons someone might need to be admitted. Urgent imaging is reinforced again there too.
Yes, it's a recurring theme. For the acute presentation, managing that severe pain, the notes state NSAIDs, non-steroidal anti-inflammatory drugs, are first-line analgesia.
Like ibuprofen or ketorolac.
Exactly. Antiemetics for nausea, rehydration as needed, urgent imaging again. They also note that watchful waiting might be appropriate for asymptomatic renal stones, stones sitting in the kidney but not causing blockage or symptoms.
Okay.
And M-meat with alpha blockers like tamsulosin is specifically recommended in the notes for distally located stones, stones that are further down the ureter, closer to the bladder. The idea is to relax the ureter to help passage.
Right, helping it squeeze the stone out.
Kind of relaxing it so the stone slips through easier, yeah. For managing patients at home, if they're discharged, the notes give key advice. Drink plenty of fluids and try to catch any past stone for identification later. Standard analgesia like paracetamol, maybe with codeine if needed, can be used.
Okay. Back to surgery briefly. The notes list the options again in another spot.
Yes, it seems surgery or procedures are considered for things like intolerable pain, or if the stone is just considered unlikely to pass on its own due to size or position. The options listed again are ESWL, PCNL, ureteroscopy, and occasionally open surgery, though that's much less common now. For bladder stones specifically, percutaneous approaches through the skin, or ESWL for high-risk patients are mentioned.
Got it. And the final piece of management seems to link directly to prevention, right? Ongoing care.
Exactly, yeah. Ongoing management focuses heavily on reducing recurrence because, as we'll see, it's common. Key strategies listed: increased hydration, dietary modifications, and sometimes medications.
Well, medication.
Specific medications for prevention are listed based on the stone type found from analysis. Things like potassium citrate or sodium bicarbonate might be used for uric acid and some calcium stones to make the urine less acidic. Allopurinol for certain calcium oxalate stones related to high uric acid levels, and urease inhibitors for those infection-related struvite stones.
Tailoring prevention meds to the stone chemistry makes sense. That's a really thorough overview of management based on the notes. Now, what's the outlook? What did the notes say about the prognosis for someone with kidney stones?
Well, the general prognosis is stated as good, provided there's proper management. Most stones are treatable.
That's reassuring.
The notes provide some specific passage rates for ureteral stones. Stones up to 4 millimeters in size have a very high chance, 95%, of passing on their own within about 40 days.
So small ones usually pass.
Usually, yes. For stones between 5 and 10 millimeter, the spontaneous taffage rate drops to about 50%.
Okay, so size is definitely a major factor for natural passage. Bigger stones get stuck more often.
It is a key predictor, and the notes include a really crucial and perhaps surprising detail on recurrence. You ready for this?
Lay it on me.
The recurrence rate is stated as 50% at 5 years and a striking 80% at 10 years for those without previous stones.
Hold on, wait. 80% recurrence at 10 years, even if this was their first ever stone. That rate feels incredibly high. Are we reading that right from the notes?
Yes, according to these specific notes, that is the figure provided. Recurrence rate for those without previous stones, 15% at 5 years, 80% at 10 years. It's stated just like that. It really underscores just how high the long-term risk is once you've experienced a stone event, even the first one.
Wow. Okay, well, that makes the next section even more critical. Given that potentially very high recurrence rate, what concrete steps for prevention do the notes recommend to try and stop that 80% statistic from happening?
Right, prevention is key. Based on the notes, the main preventive measures are increase fluid intake significantly. The target mentioned is 2-3 liters per day. The goal is to keep the urine dilute.
Dilution is the solution to pollution. Stone pollution.
Exactly. Keep things flushed out. They also suggest adding lemon juice to water. The citrate in lemon can help inhibit stone formation and avoiding carbonated drinks, particularly colas, which might increase risk.
Okay, simple tips.
Reducing salt intake is important, as sodium can increase calcium in the urine. Maintaining a healthy diet and weight are also listed as general preventative measures.
That makes sense. And what about calcium intake? We said calcium stones are the most common, so should people limit calcium in their diet? Avoid milk and cheese.
This is crucial, and the notes are very clear. Do not restrict calcium intake. This is a critical point for revision, a potential exam question, perhaps.
Why not? It seems counterintuitive.
Because restricting dietary calcium can actually, paradoxically, increase the risk of the most common type, calcium oxalate stones. It affects how oxalate is absorbed in the gut. So the advice from these notes is to get a normal amount of calcium in your diet. Don't actively avoid it.
That's a vital myth to bust based on these notes. Do not restrict dietary calcium. Got it.
Yes. And finally, as we touched on in ongoing management, medications based on the specific stone composition, identified through analysis, are part of the long-term prevention strategy for some people.
Right. Tailoring treatment and prevention to the actual stone type. Okay, great. So to wrap up our deep dive into these notes, what are the potential problems or complications if stones aren't managed properly or if they cause significant issues?
Right, the downsides. The notes list several important complications. Urinary tract obstruction, obviously. Hydronephrosis, which is that swelling and potential damage to the kidney due to urine backing up behind the obstruction.
Correct.
Urinary tract infections are common, often occurring secondary to the obstruction and stasis. Kidney damage itself, which the notes warn can become irreversible if obstruction is complete or prolonged. And of course, recurrent stone formation, which we've just discussed at length due to those high rates.
So they can directly harm the kidney itself, potentially permanently.
Yes, the notes state that complete or prolonged blockage can lead to irreversible renal damage. They also quantify risk a bit. Ureteric stones still causing symptoms after about 4 weeks carry a 20% complication risk. An infection occurring with a persisting obstruction is specifically highlighted as potentially life-threatening. Sepsis is a real danger.
Serious risks to be aware of. Need prompt management.
Definitely. The notes also mention some potential longer-term associations. Kidney stones are linked in some studies to renal cell carcinoma, RCC, and upper tract urothelial carcinoma, UTUC, in certain age groups.
But cancer link?
An association noted in the source material, yes. There's also a possible link noted to coronary heart disease and stroke. The inflammation or metabolic issues might play a role.
Interesting. Broader health implications then, potentially. Anything else listed under complications?
Just one more rare complication listed, rupture of a renal calyx. That's one of the cup-like structures inside the kidney where urine collects, which can lead to a collection of urine leaking outside the kidney system called a urinoma.
Okay, quite the range of potential issues. That covers the complications outlined in the notes. We've really gone through everything you provided, from the definition and causes, through all the risk factors, how they form, what else they could be, who gets them, how they present clinically, how to investigate, the whole management spectrum, the prognosis, crucial prevention tips, and the potential problems.
Yeah, we've tried to extract the key points and connections within your source material, hitting all those sections.
It's been a comprehensive deep dive into kidney stones, guided entirely by your notes. And as we finish, here's that final provocative thought for you, the listener, to consider, building on what we've covered. Given that really high recurrence rate we saw potentially up to 80% at 10 years, even for those without previous stones, according to these notes, what's the single most important, actionable step you would take? Or perhaps advise someone else for prevention after learning all this? Something to mull over.
That's a valuable question to keep in mind for applying this knowledge, definitely.
Absolutely. Well, that brings us to the end of this deep dive into renal calculi based on your notes. We really hope taking this journey through the material with us has been high yield and helpful for your revision and understanding.
Thank you so much for providing the source material. It genuinely makes these deep dives possible and allows us to tailor them to exactly what you need to focus on.
Our pleasure entirely. And remember, if you're looking for more revision resources, you can find them over at pasthemsray.com.
That's right. And for free resources, definitely check out freemsray.com.
So that's pasthemsray.com and freemsray.com. Thanks again for joining us for this deep dive. We'll see you next time.